Welcome to this edition of the If You Were My Family Member Cancer Patient Series. Today, we're going to talk about multiple myeloma in a way I hope will help everyone who's afflicted with the cancer and their family members. Today is episode 1 of 2. I really wanted to put all of multiple myeloma into 1 hour, but it was impossible. When I thought about trying to convey everything I wanted to tell patients and their loved ones about the disease, I just couldn't do it in 1 hour. So it's going to be part of it done today and part of it done next week. So when people are diagnosed with multiple myeloma, just like any other cancer, people go through a gambit of emotions. I always tell patients that I've treated cancer for a very long time. I've thought about cancer since I was 4 years old when I first saw a cancer cell in my dad's laboratory under a microscope. But even though I've thought about cancer for the last 42 years, I'm 46 now, until you have cancer, there's absolutely no way that you would understand what it's like to have cancer. It's just not something that you can fully understand. And so when patients are diagnosed with cancer, they certainly go through a gamut of emotions. They go through phobia and panic and depression and stress, and that's all completely understandable. Those are normal reactions to an abnormal situation, which is multiple myeloma. But what we want to do with this series is we really want to try and lift the curtain, right? Part of the issue when you're diagnosed with multiple myeloma is the fear of the unknown, not really knowing what the future holds. And we're going to try and address some of these question marks and really give you answers for those so that you know exactly what your personalized journey is going to look like. And so you're not so afraid because there's not as much unknown. Now, what I think that we do uniquely relative to all the stuff you can see on the internet or whatever you're hearing is that we're really going to talk about the forest as much as the trees. And we're going to try and give you the 30,000-foot view, but we're also going to try and take you into the trees in a way that's easily digestible in a very facile manner. But what we do better than most people on the planet, I think, is that we don't just talk about the trees, right? We don't just talk about the forest. We really can take you to the country, to the continent, to planet Earth. And so we're going to be kind of going in and out from planet Earth down to the trees and up to the forest and up to the country and really give you a full appreciation of what you're about to go through in a way that I think you can take with you. The world of multiple myeloma is changing so fast. It's incredible. This disease is changing every single day. And so what I tell you today may be rendered obsolete in a year, but I'm trying to give you basic principles, something you can take with you for the rest of your life that you can really rely on and have a foundation that you can really assimilate new information with. And I think we're going to do a pretty good job with that. So before we even start, when you're diagnosed with multiple myeloma, that's terrifying. You just don't know what to expect. The minute you get diagnosed with cancer, your life is never the same. And I think that people who have cancer can truly appreciate that. But what I really want to convey with this talk, and really the take-home message from here, from all of what I'm about to describe, is that there is a ton of hope when it comes to multiple myeloma. We are very good at this disease. I actually love treating it because we are so good at treating it. And really, hope does spring eternal with this disease. You don't have an expiration date when it comes to multiple myeloma. Now, multiple myeloma theoretically is an incurable disease. But when all is said and done, please know that you do not have an expiration date. You didn't walk in the door with an expiration label, and I expect you to do very, very, very well. Treatment in this disease is incredibly effective. We're very good at treating myeloma. Like I said, it's one of my favorite diseases to treat because we can change your situation overnight. And I mean it, like within weeks, we can change your entire situation in a good way. And so we're very effective at treating myeloma, and we're getting better. That's the amazing thing. We're actually getting better. It is not unheard of to live 20 plus years with this disease. And I think we're going to do even better than that. I do think someday we might be curing this disease. In fact, right now we can, but it takes a lot, and I'll talk about it in a moment. And in fact, it's pretty rare that we actually can. But the bottom line is, I think in the future, we will potentially be curing this disease. We're very good at this. So please know there's a ton of hope. There are many new treatments that were approved relatively recently. We'll talk about those. And there are many promising treatments on the horizon. We'll talk about those too. So what I am trying to give you, which I hope is unique, if it's not unique, then I don't really know the value behind what we're doing. I probably should stop. But the idea behind what we're trying to do for you is we're trying to give you a personalized journey for you and your loved ones. And we're really trying to take you through the entire process that multiple myeloma patients are going to experience so that there is no unknown, so that you know what to expect, so that you can properly advocate for yourself and your loved one. And that's what we're trying to do here. And I hope we do that in a way that's remarkable. I hope this is of value to you. But what I would advise you to do when you really kind of are diagnosed with multiple myeloma or your loved one is to watch the initial talk I gave called Optimizing Your Ability to Fight Cancer. It kind of lays the premise, lays the foundation for everything you're about to hear. Certainly you don't have to watch that now. You can watch that after you watch this talk. But if you watch that talk, it really sets things up very nicely for the next two talks, which is really episode 1 of this, everything you need to know about multiple myeloma, which is this talk, and episode 2, which we'll be doing next week. So when we talk about multiple myeloma, very, very simply, although the word doesn't really suggest it properly, multiple myeloma really is just a process where a plasma cell grows in an uncontrolled way. So plasma cells are integral components of our immune system, and they are made in the bone marrow. So here's what happens in your bone marrow. So in our bone marrow, we have stem cells that essentially replenish the blood cells that we need throughout our lives, okay? But at some point, a stem cell decides to mature into an adult, and it can mature into any number of cells. It can become a platelet, otherwise known as a thrombocyte. It can become a red blood cell, otherwise known as an erythrocyte. It can become any series of white blood cells, including a plasma cell, which is really derived from a B cell lymphocyte. So it initially is a B cell lymphocyte and then matures into a plasma cell. Don't allow any semblance of confusion to happen here. You don't need to know these details. It's not a big deal. Just appreciate that plasma cells are made in the bone marrow, and that multiple myeloma really is a situation where that plasma cell grows in an uncontrolled way. And that plasma cells essentially circulate in the blood to get to where they need to get. So plasma cells are fundamental components of everyone's immune system. We all have them. They're really important. We all have them. It's just that in multiple myeloma, one of these plasma cells decides to grow in an uncontrolled way. But plasma cells make antibodies to fight infection. So here's a virus, right? And here's the plasma cell basically making these antibodies that bind to the virus and then are phagocytosed by the immune system cell, essentially kills them. So that's all that means, right? So we make antibodies with plasma cells. Those antibodies basically identify the foreign microbe, the foreign pathogen like a virus or a bacteria, and then facilitate their destruction by the immune system, which is depicted here. Now, antibodies, and this is important, so I really need you to get this part of it. Antibodies are typically comprised of 2 heavy chains shown in blue here and 2 light chains, okay? Now, there are many types of antibodies, and they're determined by the nature of the heavy chain and the nature of the light chain. So if the heavy chain is IgG and the light chain is kappa, then you have an IgG kappa antibody. And it's that simple. It's really, really that simple. But the nature of the antibody is determined by the type of heavy chain depicted here and the type of light chain. Now, there are different types of heavy chains, IgG, IgA, IgM, IgD, IgE. Those are shown here. Now you can see they have different structures. They do different things. So the type of heavy chain and the type of light chain, the type of antibody that your plasma cell is making matters a lot, right? So our plasma cells typically make many types of antibodies. So there'll be antibodies with different types of heavy chains and different types of light chains. What's unique about multiple myeloma and the cancer cell in this case is that the plasma cell, because it's growing in an uncontrolled way, making copies of itself, is making the same antibody, okay? And that's the key. You have a cell that's growing in an uncontrolled way, making too much of a particular antibody. So like we talked about, multiple myeloma, well, cancer in general is just a cell that grows in an uncontrolled way, breast cancer, breast cell, lung cancer, lung cell. But in multiple myeloma, it's a plasma cell that proliferates in an unchecked manner. So you can see that depicted here. It typically, right, is going to be in the bone marrow. It's where these cells reside. And so in a normal process, you have normal plasma cells that make many different types of antibodies. But what happens in multiple myeloma is the plasma cell grows in an uncontrolled way, and it makes a specific type of antibody. They make what's called a monoclonal antibody. So you've got one clone, so mono, just one, right? One cell growing in an uncontrolled way, making a monoclonal antibody. The antibody that's being made is all the same. So that's really what multiple myeloma is, okay? And the reason I'm harping on this is because you need to know your multiple myeloma. You're going to need to know what the monoclonal antibody is that your specific myeloma is making. So different myelomas can make different antibodies, right? So somebody's myeloma might make an IgG kappa, somebody's myeloma might make an IgA lambda. that matters, okay? So it's important to know what your specific myeloma does in terms of the antibody it makes. So the two big issues that we see with myeloma, or the two primary reasons it causes problems, is because number one, it basically grows in the bone marrow, right? So this plasma cell is proliferating in the bone marrow. And because of that, it can essentially crowd out the normal cells that make the other cells that we need, right? So here's your bone marrow. You can imagine if the plasma cell is growing in an uncontrolled way, there's not enough room to make these other normal cells that we need, particularly red blood cells, which carry hemoglobin in our body, which carries oxygen. So that's one primary reason multiple myeloma causes problems, because it's residing in the bone marrow and it's crowding out the bone, okay? The second reason that myeloma causes problems is because of the antibody it makes. These antibodies can wreak havoc when they're in large amounts, or they have a particular type of heavy chain associated with them, or a particular type of light chain. And so the antibody itself can cause problems. So it's not just the cell growing in an uncontrolled way in the bone marrow that's creating havoc. It's also the antibody that's being made. So the signs and symptoms of myeloma, because of the cell growing in an uncontrolled way, and because of the antibody being made, basically are described by this mnemonic that we say CRAP, right? So C stands for an elevated calcium. We'll go over that in a minute. R stands for renal problems, so kidney issues. So renal is just another word of saying kidney. A stands for anemia, right? So a low hemoglobin, that's all that really means, just from a low red blood cell count. And B stands for bone problems, which we're going to talk about in a minute. So let's start with the calcium issue, okay? So don't let this get too complicated. Don't worry about the details. I'm just trying to give you the big picture, just so you have a fundamental understanding of how to look at myeloma and how to really prepare for your journey if you're not already on the journey. And if you're on the journey, how to really assess how the journey is going, right? So we see an elevated calcium in multiple myeloma because there's bone damage from the actual cancer. When there's bone damage, it causes the bones to release calcium. And that's why the calcium goes up. There's other reasons for it, but that's the primary reason, right? And so when you have a high calcium, we typically think of this mnemonic. So bones, stones, groans, and psychiatric overtones. That essentially means if the calcium's super high, you can have bone issues, you can have bone pain, you can have kidney stones, because the calcium itself can cause kidney stones. You can have abdominal pain, so we say groans. So abdominal discomfort, you can have constipation, or you can have altered mental status. So it can mess a little bit with your head. And in fact, if the calcium's super high, you can have some issues with confusion or lethargy because it's affecting the brain. Now, the way to look for your calcium, really simple. Just go to the basic metabolic panel. It's a blood test that they're doing on you every single time, or the comprehensive metabolic panel, and you will find the calcium here. Now, we typically need to adjust the calcium for the albumin. I'm not going to go through that. It's not important. If your calcium's high, it will be pretty obvious. So a normal calcium is roughly 8.5 to 10.5. Now, it depends on the lab, depends on where you are, but that's pretty consistent with what normal is throughout the world. So here you can see this patient who had multiple myeloma came in with a calcium at 12.4. It was elevated. And so you can see that depicted here. It's the blue line. So between the green and the blue line, that's normal. You can see this person's calcium was normal, and then it increased to 12.5 or 12.4, okay? Now, we are very good at treating high calcium. We typically give a drug called Zometa or a drug called calcitonin, whatever. We typically use a drug called Zometa, and we hydrate people. But the bottom line is we're very good at treating it. Don't worry about those details, okay? And so this person's calcium immediately within a day, right, dropped nicely to normal. So we're very good at treating this. But just understand that one of the issues with multiple myeloma, because it causes punched out areas in the bones, which releases calcium into the blood, is that you can see an elevated calcium. The second problem that you can see through this mnemonic or through this acronym is renal problems, kidney issues, okay? So what happens, and again, don't worry about the details, I'm gonna make this really simple. What happens is the abnormal protein being made by your cancer cell can essentially clog the kidneys. It can cause something called a cast nephropathy, which can damage the kidneys. That's all I want you to hear, right? That's simple, okay? It can damage the kidneys. In addition, the cancer cell itself can actually infiltrate the kidneys and cause a problem. But the bottom line is you can see kidney dysfunction from this cancer. That can cause difficulty urinating, fatigue, altered mental status, you're just confused, electrolyte problems, issues with potassium, issues with sodium, right? Whenever you have a significant amount of kidney dysfunction. So The way to look at your kidney function, the way to measure it, okay, is we use something called the creatinine. Now, a lot of people don't really understand creatinine, so let's just talk about it for a minute. The lower the creatinine, the better, right? The better your kidney function is. And the way to think about it is when your creatinine doubles, when it goes from 1 to 2, that means you've lost 50% of your kidney function. It's that simple, okay? So most people's creatinine is going to live under 1.3 roughly. So if your creatinine doubles, so you might be someone who has a creatinine of like 0.6 normally, and it goes to 1.2, that means you lost 50% of your kidney function. So that's the way to look at kidney function. You're going to follow the creatinine, okay? Just like in this case, you can see the creatinine's here. It's in the basic metabolic panel. It's just like the calcium. It's going to be in the same panel. You can easily find it in your blood test. When you're looking at your chart, your my chart, or whatever you're looking at with respect to your medical record, right? You can easily find your creatinine and you're just going to track it. You're just going to watch to see what it does. So you can see this patient had a creatinine roughly 0.8, right? 0.79. That's where their kidneys normally live. And you can see the myeloma caused their kidneys to worsen. The creatinine doubled initially, or more than doubled, and then got worse, right? Because the myeloma was affecting the kidneys. Now, this is over a couple of days. This actually got better. Please don't worry. But the bottom line is that's how to look at kidney function. And you can see it here, actually. So normal kidney function between the green and the blue bar. You can see his kidney function was pretty normal. And then all of a sudden, because of the myeloma, just acute diagnosis of it affecting the kidneys, the creatinine got worse and the kidney function correspondingly was worse. Okay. And so that's the way we look at kidney function. Sometimes when the kidney function gets too bad, patients require dialysis to get out of trouble. So that if you have an issue with your kidneys that's severe enough from the myeloma, you may require dialysis. Now, I don't often see myeloma cause kidney dysfunction. It certainly happens. I've had many patients with it, but it's not the most common occurrence. Okay. It's relatively infrequent. Now, to address this problem, you have to treat the myeloma, right? You just have to treat the myeloma to really resolve this issue. And plasmapheresis, this thing where we can take out your plasma and replace it with normal plasma, that's controversial. A lot of people don't do it. In this case, I just put it here just in case you hear about it. So we talked about the high calcium. We talked about the kidney issues. Let's talk about the A part. Let's talk about the A part of the crowd. So some people can have an anemia, right? So anemia is where the hemoglobin, which is the molecule that transports oxygen in our blood, is below normal. So a normal hemoglobin in females is 12, roughly 12. Some people say 11.5, but let's say 12 to 14.5, roughly, let's say 15. And a normal hemoglobin in males is roughly 13 to 16.5, okay? Now take that with a little bit of a grain of salt. There's a little wiggle room there. It depends on who you talk to, but that's what a normal hemoglobin is. Now, because of what we talked about with the plasma cell, the cancer cell in myeloma, infiltrating the bone marrow, you crowd out the normal cells. So you can't make the red blood cells and you can't make the hemoglobin associated with them properly. That's why the hemoglobin goes down. So the way to look for your hemoglobin is to simply look at your complete blood count. So again, it's going to be in your chart. It's really easy to find. So you'll look for hemoglobin, a normal hemoglobin we already talked about, right? So you can see that this person's hemoglobin is really low because of their myeloma. So again, between the green and the blue line, it was normal. So purple is what his hemoglobin was. You can see it dropped precipitously when he was diagnosed with myeloma. So that's all you need to know there. You just look at your hemoglobin. Ideally, it would be normal, but just understand that myeloma can make it low, largely because of what we talked about, the reduced production of red blood cells and hemoglobin, because the plasma cells are infiltrating the bone marrow. They're just crowding everything out, okay? Now, signs of a low hemoglobin include fatigue, shortness of breath, particularly when you're exerting yourself, when you're walking, or you're trying to do activity, dizziness, lightheadedness, that can certainly be a manifestation of anemia, chest pain, weakness, etc. So, you know, a lot of my patients, they'll be like, I've had these weird symptoms for so long, I don't understand it. And they come in and we diagnose them with myeloma, we see their anemia is low, and finally they appreciate why it's happening. It's not all in their head. They're not going crazy. It actually is related to having a low hemoglobin and having the disease. So to solve this problem, oftentimes we have to give blood transfusions to get people out of trouble. Like if the hemoglobin is less than 7, we're definitely going to give you a transfusion, as in this case. But really the ultimate treatment is to treat the myeloma. That's absolutely imperative. Just like everything else, you have to treat the underlying wound, right? A lot of this stuff like dialysis or transfusions, that's like putting Band-Aid on the wound. The wound itself is the myeloma. You have to fix the myeloma or the problem's just going to recur. The last part of this acronym is the bone issues that myeloma can create. Now, this is what we see a lot when people come in with symptomatic myeloma, which essentially all myeloma is. So the bottom line is, when we talk about active multiple myeloma, a lot of people can get these punched out areas in the bone. So the plasma cells themselves cause what we call lytic lesions. So punched out areas in the bones that we can see on scans. And you can see it here. There's cancer up and down the spine in numerous bones here in the ribs on both sides, in the femurs on both sides, and in the pelvis on both sides. So you can see there's a lot of cancer here. That's pretty common. Now, the beauty of this is that when you treat this patient, this will probably all be gone in a matter of a couple of months. So we're very good at treating this. Please don't worry if your scan looks like this when you start. Please know there's a ton of hope. But as you can imagine, right, the symptoms you're going to feel for this depend on the location and the extent of the cancer. If you got disease in the spine, you might have pain in your back. You could have spinal cord issues because the multiple myeloma cancer can impose on the spinal cord. So the symptoms you're going to have are very much dependent on where your cancer is, which is why I always tell people no two myelomas are the same, right? No two cancer patients are the same. We're going to go over that later, but please know that when it comes to bone issues, it very much depends on where the cancer is. Now, there are many ways that we look to see where the disease is regarding the bones. Okay, don't worry about this. I just wanted to give you all the examples, but please don't worry about this. We used to do x-rays, right? We used to do what's called skeletal surveys, and we could see these punched out areas. You could see it here in the skull that would help us determine if someone had lytic lesions in the bones. We don't really do this anymore. It's kind of fallen out of favor. It's not sensitive enough, not good enough, okay? So what we do now is we do either a PET CT or a whole body MRI or a low dose CT that's a whole body low dose CT. I like PET CTs. Insurance companies are now pushing back a little bit on that, making people do MRIs or low dose CTs, but most insurance companies still let you do PET CTs. So I think most physicians in this space, most experts prefer PET CTs, but obviously there's many right choices here. There's nobody that's wrong in ordering any of these tests, but I want to just show you for a moment what you might see. And you can see here on the PET CT, you can see the cancer in the bones. Here in the MRI, you can see cancer in the bones, just these spots here, right? And then on the CT, you can see cancer in the bones. So just these spots. Now, when we talk about bone issues from multiple myeloma, what you need to appreciate is that this would be one of the rare times in this disease where we might have to consider surgery. So let me back up. Multiple myeloma in general is not a surgical disease. It's not something where we typically operate on patients. We only really do so if they're in trouble. And you can see it in this example, right? You have the spinal cord, which is depicted here, okay? And the multiple myeloma has created an issue where there's spinal cord compromise, where the spinal cord is being compressed. And that's a concern. So in this case, surgery would likely be warranted, where they would just go in and rectify this problem, and that would essentially be it. So sometimes surgery is necessary, but please know in general, with multiple myeloma, you're not going to get surgery, okay? Similarly, this is not a disease where we do a whole lot of radiation. We do sometimes do radiation to get out of trouble, right? So this would be a situation where you might radiate this area to try and get out of trouble. But in general, please know that we don't typically do radiation with multiple myeloma. It's oftentimes external beam radiation therapy. Even could be SBRT. Like, I won't go through this, but the bottom line is it can be localized radiation or it can be radiation that gets a bigger spot. It's typically localized radiation, so more SBRT. Sorry, I misspoke there, but mostly SBRT, okay? Sometimes we give steroids. So sometimes spots like this can cause a lot of swelling around the spinal cord, okay? So we'll oftentimes give steroids like Decadron, a drug called Decadron, to help reduce that swelling, to help decompress the spinal cord related to that swelling. We do oftentimes use bone protective agents. So you're going to hear about these drugs, hear about a drug called Zometa, you're going to hear about a drug called denosumab. These are drugs we give to keep the bone strong so there's not a whole lot of fractures related to the cancer in the bones. So you're likely going to receive one of those. The side effects of those are that they can cause issues with the jaw, and they can cause your calcium to go down and sometimes can cause atypical fractures. I don't want to go through this too much. These are relatively rare. They're typically associated with people with dental issues, particularly the issue with the jaw. But I won't go through that. I'll let your doctor do that. They're going to do a phenomenal job of that. But the bottom line is you can sometimes see issues with the jaw, right? And the biggest solution to all these issues, just like we talked about before, is you have to treat the myeloma. That's really important. Now, we talked about the CRAB mnemonic. We talked about the CRAB acronym, sorry. Talked about the calcium going up. We talked about the kidney dysfunction, the R, renal dysfunction. We talked about A, which is anemia. We talked about B, which is bone problems. So we understand the issues that you can see with multiple myeloma. I do need to talk a little bit about something called plasmacytomas. These are rare, okay? These are not something you're typically going to encounter. But to be thorough, I just need to put one slide on this. Okay, so let's talk about plasmacytomas. Well, we talked about how multiple myeloma is where the plasma cells growing in an uncontrolled way in the bone marrow, right? But sometimes a plasma cell can form a massive tissue somewhere else outside of the bone marrow. And we call that a plasmacytoma. It's a ball of plasma cells, basically, right? It's a mass of plasma cells. And so that can happen in numerous locations. So in this case, it's happening in a patient's sternum, right? The bone in front of their body, essentially, right? And so with plasmacytomas, if they're solitary, if they're independent, if there's no other plasma cell disease anywhere else, you can oftentimes treat them with radiation alone, and sometimes you can cure them. So sometimes a patient walks in with a solitary plasmacytoma, just a ball of cancer somewhere, right? Ball of plasma cells somewhere. You can radiate them, and sometimes, although infrequently, you can cure them. And so that's just something I wanted you to hear. Sometimes you'll have plasmacytomas where the mass is on your skin or something. It's exceedingly rare. I just wanted you to understand what that looks like. So when we talk about multiple myeloma, this slide is really, really important. This is essentially how we diagnose it and how we follow it, okay? So couple things. Number one, you want to make sure you see the multiple myeloma, right? You may have some indications that multiple myeloma is going on, but you need to prove it. You know, it quacks like a duck, looks like a duck. You need to make sure it's a duck. So how do you do that? Well, the way you make sure it looks like a duck is you look at the bone marrow, right? We just talked about how the plasma cells grow in the bone marrow. So you do a bone marrow biopsy to look inside the bone marrow. You want to see how many plasma cells are there. Now, to really qualify with a diagnosis or as a diagnosis of multiple myeloma, you have to have more than 10% of the cells in the bone marrow be plasma cells, assuming you don't have plasmacytoma. I don't want to go through that. But the bottom line is, to have a diagnosis of multiple myeloma, you have to see 10% or more plasma cells in the bone marrow. Okay, so the bone marrow biopsy is really, really important. Now, what we also do, though, and this is important too, is we do some genetic testing on the cancer cells themselves. And we do it because we want to put the multiple myeloma into a box. So there's two boxes, right? There's a high risk box and there's a standard risk box. And so we're trying to define which box your multiple myeloma is in. And to do that, we have to look at the genetic composition of your cancer cells. So we do things called cytogenetics, FISH, and NGS. I'll come back to that. Don't worry about it. But the bottom line is that's how we put your multiple myeloma into a box, right? Because remember, I told you, no two myelomas are the same. When we meet you, we're trying to say, okay, what is your myeloma? What's your specific cancer look like? Nobody else matters in that moment, right? The only person that matters is you. And when we're trying to address your cancer, we need to understand it. And so we do that by really understanding what's going on with the genetics inside the cancer cell. Next, we talked about looking at the cancer cells through a bone marrow biopsy. Now we're going to focus on the abnormal protein. So I told you that a lot of what happens in multiple myeloma is due to the abnormal protein. The kidney issues are due to the abnormal protein, right? So we talked about how important that really is. When you monitor your progress, when you're trying to follow your multiple myeloma, one very critical way to do that is to look and see, is the abnormal protein going down, right? Consistent with the cancer cells dying. You would expect if the cancer cells are dying, they can't make as much abnormal protein, you'd want that number to go down. So I want you to appreciate that there are 4 ways that we assess the abnormal protein in your blood. And you're just going to write these down. You're going to look at these every single time that your doctor is reassessing your multiple myeloma, and you're going to track these yourself. I'm going to teach you how, right? So we do something called a serum protein electrophoresis with immunofixation electrophoresis. Don't worry about it. Just write down the abbreviation, write down the acronym for it or the abbreviation, and I will come back to it, okay? We do what's called a urine protein electrophoresis with immunofixation, okay? We also do light chain analysis, and we do immunoglobulins. Okay, I'm going to come back to all of this, so please don't worry about it. But the bottom line is we do 4 tests. 3 of them are blood tests. 1 of them is urine. Okay, so these 3, the SPEP, the light chains, and the immunoglobulins are blood. The UPEP is urine. Okay, so there's 4 tests to track your abnormal protein, which essentially tracks the progress of your myeloma. I will come back to it. Okay, now we talked about the calcium, we talked about the kidney problems. So we either do what's called a basic metabolic panel. Most of us do a comprehensive metabolic panel. Basically, the basic metabolic panel gives you the electrolytes in the kidneys. The comprehensive metabolic panel gives you all of that plus the liver. So we typically do a comprehensive metabolic panel because we want to know what's going on with the liver too. But the bottom line is you'll get all of this information just from this one blood test. Okay. You'll get the anemia part, the hemoglobin part, just by looking at the complete blood count. Okay. You'll get the bone part by doing one of the imaging tests we showed. I like to do PET CTs, but that's important. Just you could get an MRI or low dose CT, but regardless, it's important to know what's going on in the bones. And this is how we do it. Not complicated. Okay. There are a couple more tests we do that are important only in terms of kind of giving your myeloma a stage. I'll come back to that, or looking at other things. We do is called a beta-2 microglobulin, okay, which really helps us determine the stage. We do an LDH, kind of put it in a box in terms of what we think high risk, low risk. I'm not going to talk too much about that today, but we do these blood tests. And so I just wanted you to know about that, particularly the beta-2 microglobulin, which I think is important. The LDH is important. So let's move on. All right, let's talk about the bone marrow part. Okay, so it's very important to know how many plasma cells are in the bone marrow, right? We talked about how myeloma is defined as more than 10% or more plasma cells in the bone marrow, right? So that's really important. So we need to do a bone marrow biopsy. So this is a depiction of a bone marrow biopsy. It sounds a lot worse than it is. Now, I've actually never had a bone marrow biopsy on myself. I've done more than 100 on patients. So I definitely know how to do them. I've done many of them in my career. But the bottom line is we typically take a needle and we go into the butt bone essentially, right? So we're going into the posterior superior iliac crest. So we're just going into a very safe area where there's not a lot of stuff that lives around it where you can puncture it and cause a problem, right? We go into the bone marrow, okay? And we extract a sample of the bone. It's typically roughly 1 to 2 centimeters and typically very, very thin. There's almost no scar from this procedure. It's really just a nick, right? And we then look at that bone under a microscope. We also take what's called an aspirate sample. We just draw some of the bone marrow out so we can do some more testing, okay? This procedure, honestly, and someone who's really good at it can take less than 15 minutes. They numb the area or they kind of anesthetize you. They do what's called conscious sedation, like you have for a colonoscopy, right? So they don't really put a tube in your throat, you're not intubated, but they'll anesthetize you to try and make it so it's not painful, right? And so they're trying to minimize the pain, but it's a very simple procedure. It takes minimal time and it's incredibly informative. And you're going to have a lot of these during your multiple myeloma journey. It's a necessary evil, but I think that you'll do really well with these. So we do these bone marrow tests to assess how many plasma cells are in the bone marrow. And what you can see here is here's a patient who had plasma cell myeloma in the bone marrow with 90% of the bone marrow cells being plasma cells. So this is a lot, okay? But the idea is you want to kind of do a before and after, right? You want to know what the number was initially, and then you want to see that number obviously go down, essentially 0. And so you'll do a bone marrow later to find out what it looks like after treatment. But this is kind of very important to know. We do a bone marrow biopsy. We also do the bone marrow aspirate because we send those tests for the genetics, right? So we do something called cytogenetics. Now, listen, this can get complicated. So I'm going to back up and tell you not to worry about the details. Just appreciate that we are doing several tests to look and see which genetic mutations are in the cancer because we're trying to put it into a box. Is it a high risk box or a standard risk box? Okay, so cytogenetics really just means we look at the chromosomes in the cancer to see if there's any obvious abnormalities. So in our body, okay, we have 46 chromosomes, 23 from mom and 23 from dad. Okay, so there's X and Y here. So if you're female, you get an X from dad, X from mom. If you're a male, you get a Y from dad and an X from mom. And you can see you get basically a chromosome from mom and dad, and they're numbered 1 through 22, and then you got the sex chromosome. Not a big deal, okay? Now, cytogenetics allows us to kind of take a global look at what's happening with the chromosomes. Is there an obvious abnormality? Fluorescent in situ hybridization, FISH, lets us look at it a little differently. We kind of paint the chromosomes, gives us a slightly different way of looking at this. And then next generation sequencing, which we'll talk about later, okay? That's another way of looking for specific mutations. So not just the chromosome, but now we can look at each gene inside the chromosome and say, is there something that's going on? This is not that important, okay? Just appreciate that we do these tests to look and see what's happened with your multiple myeloma and which box to put it in. Okay, we also look at something called minimum residual disease. You will hear this, so I'm talking about it now just because you'll hear it. But the bottom line is, sometimes when we do a bone marrow biopsy, okay, and we look to see if there's multiple myeloma still there, sometimes we've done such a good job, we can't find the plasma cells in the bone marrow. It's not obvious, okay? But these genetic tests allow us to look at a different level. It's a much deeper level where you can look at cells that you might not be able to see very obviously in a bone marrow biopsy. And that allows us to look for something called minimum residual disease, where we're looking to see, is the disease still there at a level that we can't really detect grossly by looking at a bone marrow? So at a minimum level, and that's all that means. I'm not going to talk more about that right now. I don't think it's something you need to know too much right now. So this is a very nice example of the fluorescent in situ hybridization that we just talked about. So each chromosome essentially has a different color. So you can see here that the two chromosomes look good, right? But in this case, you can see that there's a translocation between chromosome 4 and 14. That's why they're merged together. Okay, so each chromosome should be separate. The red and the green should be separate, but in this case, the red and the green are fused. You can kind of see that here. Okay. In addition, you should have 2 copies of both, right? So this patient is missing the P53. They're missing chromosome 17, and that's why you see this missing here. You only see 1 copy of it. So we talked about FISH, we talked about next-generation sequencing, we talked about cytogenetics, but let's talk about why it's important. Let's talk about how we use it, okay? Now, I know we're getting in the weeds. Now we're very much in the trees, okay? I appreciate that. Just take a moment. Don't worry too much about these details. I'm just trying to give you the global picture so you know what people are doing, how they're characterizing your disease, and why it's important, okay? So we categorize myeloma as standard or high risk. We put it into a box, okay? And we look for genetic abnormalities. We look to see if there's deletions. Are there parts of the chromosome that are missing, right? We look for translocation. So is one part of one chromosome fused to another? So you can see here, right? Here's one chromosome and another, and there's been a translocation where part of this chromosome is fused to the bottom part of this chromosome, and the top part of this chromosome is fused to the bottom. That's what we call a translocation. So we're looking for these because they clue us in into whether or not you're in the high risk box or the standard risk box. And so we're specifically looking for some of these particular genetic abnormalities, right? So we're looking for a deletion in chromosome 17, a specific deletion. We're looking for translocation between chromosome 4 and 14, or 14 and 16, or 14 and 20, okay? And we're looking for a gain in chromosome 1, meaning there's an extra part of chromosome 1, okay? And the reason we're doing that is because we oftentimes will delineate if your cancer is high risk or standard risk. And people treat those differently. That's why it matters, okay? I actually treat them fairly similarly. We'll come into that next week. But a lot of people treat them differently, okay, and expect different things of them. That's why they're trying to put you into a box, and that's why they're doing these tests. Now, I want to be very careful here. Most people, the consensus is that if you have any one of these 3 abnormalities, deletion of chromosome 17, this specific deletion, translocation between chromosome 4 and 14, or translocation of 14 and 16, then you fit into the high-risk box, okay? Some other people also feel that if you have these 2 abnormalities, you should also be in the high-risk box, okay? But the bottom line is we're looking for these abnormalities to determine if your cancer is in the high-risk box or in the standard risk box. I guarantee you that over the next several years, this will change, okay? They're gonna add different genetic mutations to this. They might take some out. I'm guessing they won't, but they'll add some, okay? So I expect this to change. This is a moving target. But for now, please know that if you have one of these translocations, we put you into the high-risk box. So you can see in this patient, okay, we did this myeloma panel, and they tested for all of these different genetic abnormalities, and they found that there were some abnormalities, okay? And so essentially they concluded the patient had a translocation between 11 and 14. That's different. We'll talk about that later. They had a deletion in chromosome 17. And so you can see that they were in the high-risk box. Now, I don't need you to understand any of that, but I wanted you to be able to look for it if you wanted to. So where you can find this, right, is you go to your bone marrow biopsy, and there'll be a part of it that will talk about the genetic part. Okay, they'll say they did this. And then you can just look it up yourself. You can say, okay, did I have one of these translocations? If you did, that puts you into the high-risk box. And now you know. It's that simple, right? If they didn't do it, that's a problem. So I would ask about it, but I don't know anyone who wouldn't do it. And so that's all you need to know, right? You want to know your cancer's genetic composition. It kind of helps guide you in terms of understanding the future. So now we've talked about the bone marrow, we talked about the genetics. Let's talk about the abnormal protein, your cancer's abnormal protein, and how we follow it. Now, this is really important, right? Because this is how you're going to track how your disease is doing, right? So we want to know the identity and the amount of your abnormal protein. So I already told you there are many types of heavy chains and light chains that make up antibodies. So antibodies are typically 2 heavy chains, 2 light chains. Now, I want to be a little careful here. There are some myelomas, some cancers, some multiple myelomas that only make light chains. They don't make a heavy chain, okay? So please be aware of that. We're going to talk about that a little bit more in the future, but you're going to want to know what abnormal protein your myeloma makes, okay? That's really important. So you're going to want to know the heavy chain and light chain components. If there is both, there typically is, but there might just be a light chain component. You're going to want to know the type of heavy chain because it can have different impacts. If you have an IgM heavy chain, there are some concerns with that we don't have with an IgG heavy chain. Some things that can impact the nerves, some things that can impact clotting of the blood. There are things that we worry a little bit with IgM abnormal proteins versus IgG. Just be aware of that. I'm not going to go through the details, but just know that the heavy chain component matters, okay? Now, I told you before, but we're going to go into it in detail now. We follow these proteins in 4 ways. So I want you checking on this every time you have a doctor visit. Now, I want you to ask them about the SPEP with IFE, serum protein electrophoresis with immunofixation, okay? I want you to ask about this. I want you to ask about what's called the 24-hour urine protein electrophoresis with immunofixation. So they might do that every couple months or so. They won't do that all the time, right? Collecting 24 hours worth of urine is problematic. That's not fun to do. I want you to ask about your serum-free light chains and your immunoglobulins. So these 3, the SPEP, the serum-free light chains, and the immunoglobulins are in the blood. The UPEP, right, is the urine. Okay, now let's talk about why that's important. The serum protein electrophoresis gives you a measure of the total protein. It'll tell you the IgG and the kappa component kind of gives you a collective measure of what's happening, okay, in the blood. The UPEP gives you a collective measure of what's happening, but in the urine, right? How much of this protein is spilled into the urine, okay? And it gives you the IgG and the lambda or the light chain component. So the heavy chain and the light chain component gives you all of it, okay? The light chain assay gives you the light chain part, okay? The heavy chain assay gives you a measure of the heavy chain part. So you can measure the total protein in 2 ways, blood and urine, right? So blood SPEP, urine UPEP. You can measure the light chain part separately through the light chain assay. You can measure the heavy chain part separately through the heavy chain assay. So there's 4 ways to track your disease, and I want you to ask about them. And I want you to look at them and say, okay, this is what's going on with this test, and this is what's happening with my cancer. I'm going to show you exactly what to do in a minute. So let's start with the serum protein electrophoresis with immunofixation. So that's here. Okay. So here's how it works, right? We basically do a test called the SPEP, and we look for a pattern. Okay, I'm not going to go through the details of this. It's beyond what we need to talk about. And we look to see if the pattern is abnormal. So you can see here, there's a separate spike that should not be there. So you can see it's not there in the normal situation. It's there in the abnormal situation, right? So we call this an M spike. So you're going to see this called an M spike. This corresponds to your abnormal protein, your monoclonal protein being made by 1 clone of cells. It's called monoclonal for that reason, okay? So you're going to want to know what the amount of this is. I'll show that to you in a second, okay? In addition, once we find that there's an abnormal protein in the blood, we then say, well, what is it? What's the nature of it? What's the specific heavy chain and light chain component? So then we do the immunofixation part that's shown here, and that tells us what the exact problem is. You can see this patient has an IgG, right? That's that purple bar, and a lambda. That's the lambda bar. So you can see collectively, the abnormal protein being made is an IgG lambda. Okay, so we found it with the SPEP. We characterized it with the immunofixation. That's it. You don't have to know all this detail, okay? I'm just telling you one time so you've heard it. But what I want you to know is when you look at your labs, okay, you're going to look at the myeloma labs. It might be in the oncology section, or it might be called serum protein electrophoresis. It will be there, okay? you're going to look for the monoclonal peak. They might call it an M protein. They might call it an M spike, but you're going to look for this. This should be 0, right? And so here you can see there were 2 different peaks. So there's actually two abnormal proteins in the patient. Doesn't matter. Bottom line is you can see that it was very high. It should be 0, okay? And so that's what I want you looking for. I want you looking for your monoclonal peak in your serum protein electrophoresis. I want you to follow it, okay? If it goes up, that means the disease is likely getting worse. If it goes down, it means it's getting better, okay? So look at what happened in her case. So she was diagnosed all the way back in 2019 with a very, very high monoclonal protein, okay, abnormal protein. She got treated, and look, it went essentially down to 0, right? And then she was still getting treated. It came back up, suggesting the disease was getting worse. So we did something different, treated again, right? Disease did very well, then started to escape a little bit. That's what myeloma does, kind of learns your treatment and gets a little worse, and you have to deal with it in a different way. So we did it again, we treated it in a different way, and now you can see it's really excellent. So the bottom line is, this is how we follow myeloma. We're watching the monoclonal protein in the blood. So I want you to be able to identify the serum protein electrophoresis in your blood and to say, okay, what's my monoclonal peak? And how does it look? What's the trend? Trends matter more than snapshots, okay? I want to know where we are. So like, if you look here, for example, this is not a bad monoclonal protein. It's 0.9, okay? In that moment, that's not that bad. That looks good. But if you look to see what actually happened, you can see it was much worse, and now she's been treated. So we're doing really well. Better example would be, let's say you were up here, the monoclonal protein is like 4.5. That looks awful, right? That's not great. But the bottom line is, it actually was really good because she was getting treated, it was going down, and she was going to get better. And so we're in very good shape there. So I want you thinking trends, not snapshots. If you just looked at what was happening in this moment, you would be fooled. She was actually doing very well in this moment. You would think she was doing poorly. Okay, so this is one thing you're going to look at. Okay, we talked about that. Now, to find out the actual type of monoclonal protein you have, you're going to look at the immunofixation, and there's going to be a line. Okay, it's going to be something like this, saying immunofixation, right? You'll just click on it and you'll say, okay, it shows that I have an IgA kappa and an IgG kappa. So you can see she actually had 2 clones of cells, 2 abnormal myeloma cells, right? One clone was making this protein over here, the IgA kappa, and another one was making the IgG kappa. So she basically had 2 myeloma cancers essentially in one. But the bottom line is, you could see that this was depicted, each of these monoclonal proteins was depicted here, right? And then you can see the nature of the characterization of it here. So don't worry too much about it, okay? Just look at the number and look at the nature of your abnormal protein. So we talked about the serum protein electrophoresis that gives you the overall quantity of the overall protein, the heavy and the light chain, okay? Now we can also look in the urine. So we typically have you collect your urine for 24 hours, and we say, okay, is there abnormal protein being spilled into the urine? And again, very simply, you're going to look for what's called the urine protein electrophoresis. And you're going to say, okay, what does the monoclonal peak look like? Is there a monoclonal peak? First of all, there might not be, because there's no monoclonal protein, no abnormal protein there. But if there is, you're going to say, okay, how much is there? And you're going to track that just like we tracked the other one, okay? You're going to want to see that go down. And again, they can do immunofixation there, where they can also say, okay, we found this abnormal protein in the urine. Let's determine what type it is, just like we did before. And they can tell you, okay, there's an IgA kappa in the urine, okay? And that's all you need to know. So we're really good there. So we talked about the UPEP and the SPEP, and they give you the overall protein. They give you the heavy chain and the light chain, okay? Let's talk about serum-free light chain assay. This is a great test because it gives us the light chain part separately, okay? So we can look at the whole protein with the whole antibody with the SPEP and the UPEP, and we can even look at just the light chain part with the light chains. And you can see in this case, the light chain, the kappa light chain was very high, which is consistent with the fact that she had an IgA kappa abnormality, okay? So you can follow this separately. You want to see that go down, okay? In addition, you can follow the heavy chain part. You do that by doing a test called immunoglobulins. You can see here the IgA, which should be less than 300, 400 roughly. So it's 300. So it was 6,600, which is very high, right? And so you can see that this immunoglobulin test allows you to follow the heavy chain part. So we have 4 measures of what's happening with your abnormal protein. We have the SPEP, which gives us a global view. We have the UPEP, which gives us a global view in the urine. We have a light chain assay that lets us look at the light chain specifically, and we have the immunoglobulins that lets us look at the heavy chain. So now you got 4 great ways to follow your cancer. You're going to want to see all of these go down. Okay. So I want you to know your monoclonal protein. This is so important. I want you to know what the abnormal protein in your blood or your urine is from your cancer. Okay. And I want you to know the type of it, the abnormal protein there is, and I want you to follow it. So you're going to ask to see your myeloma labs. These are the labs you're going to ask about. Very simply, just ask about them. Don't worry about the details. Just ask. Okay. You're going to follow the abnormal protein just like we talked about. And just remember that the abnormal protein levels will correlate with the myeloma severity. So the higher the level, the worse your disease is in that moment, but you're going to obviously want to see it go down. It most likely will, because we're very good. And so you'll follow the trend. You won't follow snapshots. So that's excellent. I hope you understand that. We'll come back to that many, many times throughout this talk and the next one. So one thing I want to talk very briefly about, I don't want to spend a whole lot of time here, is I want to talk about staging. You know, everyone, when they hear about cancer, rightfully so, thinks about stage. We say, okay, what stage is this? Is this 1? Is this stage 2? Is this stage 3? Is this stage 4? Now, in multiple myeloma, staging is a little bit different. First of all, there is no stage 4, right? It's 1, 2, and 3. There are 2 different staging systems. So there's the revised international staging system here and the international staging system. And the way we give you a stage, right, is we basically put you into these boxes. So we look at the serum beta-2 microglobulin, look at the serum albumin. So the albumin you can get from your liver function tests. You can see this here. So from that comprehensive metabolic panel I talked about, you can see the albumin there, okay? You basically just plug it in, right? So the albumin here is 4, so you plug that in here. The beta-2 microglobulin is also a blood test. So your physician can give you that result, and you can find the result there, and you can just plug it in, okay? I really don't want you fixating on this. We use this more than patients need to, like it really doesn't impact treatment that much. It's kind of a way of saying, you know, what's the prognosis? How do we think people are going to do? I don't want you to really know this, okay? The bottom line though is if you want to know your stage, just refer to this table and we can plug you in and you can see what your stage is. What I do want you to know though, is I want you to know that no 2 myelomas are the same. That is so important. You know, I can't harp on this enough. When I see someone with myeloma, okay, I immediately just say to myself, okay, we know that no 2 myelomas are the same. So how is this myeloma going to behave? How do I have to address this myeloma? So I kind of think about myeloma as a continuum, right? There are some myelomas that are super aggressive. There are some myelomas that are pretty slow growing. They're pretty indolent, okay? And I want to know which of these arrows you are, right? I want to know where your myeloma is in this continuum, okay? Now, what you need to know to appreciate that is you need to know that multiple myeloma can have different monoclonal proteins. So your monoclonal protein could be an IgG kappa. Someone else's might be a lambda. It might be an IgA lambda. It might be something else, okay? And that matters. It can have different amounts of initial cancer. So what I mean by that is, number one, your bone marrow might have 90% plasma cells. Someone else might have 15%. Those are both myeloma, assuming everything else is going on. But, you know, those are not the same. Those are obviously different, okay? They can involve the organs in different ways or bones in different ways, right? So they can affect your kidneys differently, or they can affect the bones. It might be up and down the bones or in just one discrete area in the bone. So obviously those 2 myelomas would be different, right? They can have different genetic compositions. We talked about the standard risk and the high risk boxes. They can respond differently to treatments. And so I want you to know your multiple myeloma. That's why we just did everything we did, because I want you to understand what your specific multiple myeloma is. Now, one very important thing for you to do to truly understand your myeloma is to ask to see your scans. I want you to have your physician sit down and show you your PET scans. Look at these 2 patients. So there's a patient here and a patient here, okay? This patient had one area of disease that was related to their multiple myeloma, just this one area. We biopsied this, that was multiple myeloma. Nothing else on this scan is cancer. These are the kidneys, that's normal, bladder normal, nothing else. There's no other cancer on this scan, okay? This patient though, has disease in multiple areas, okay? In both arms, right? They have disease in both femurs. So clearly this patient is different than this patient, okay? They both have myeloma. When you look at the note, it says multiple myeloma. It doesn't say a whole lot more than that, right? But these are very different patients. So I want you to know what your multiple myeloma looks like, okay? The beauty of multiple myeloma though, like I told you, and I want you to see this, is we're very good at treating this. This is only a couple months later, right? So you can see all the disease is essentially gone. So that's the part that I want you to take away. I want you to know there's a ton of hope. We're really good, but I want you to ask to see your scans. And we're always comparing before and after, right? So this is the before, the after looks amazing. It means our treatment's working. So we're in really good shape. So you just know that no 2 multiple myelomas are the same. Your job is to find out what your multiple myeloma is and how it's behaving. And that's what everything we just went through will help you do. So this is kind of our take-home slide, our summary slide, okay? You're going to have a bone marrow biopsy. You're going to want to know how many of the plasma cells were in there, like what percentage of plasma cells were there. You want to know the genetic composition, like we just talked about. You'll want to track your antibody with these 4 tests. You'll ask about those, right? You'll track your calcium and your kidney function with these tests. You'll track your hemoglobin with the complete blood count. You'll track your bone problems, bone issues with a PET CT most likely, and then you can do the beta-2 microglobulin and LDH. Okay, that's enough. Just take this one slide with you and you can say, okay, what did this show? And they can tell you and you can kind of follow it. Very simple, okay? So when we talk about multiple myeloma, right, we've just given you the background that you need to really fight this properly. And so I always tell people when you're treating cancer, like multiple myeloma, or when you're fighting it, I want you playing chess, not checkers, right? I want you thinking several moves ahead. I want you preparing for the future and the present. I want you to appreciate what's going to happen as much as what is happening. You want to think several moves ahead of this cancer. So when I talk about cancers that are theoretically incurable like myeloma, now again, there's a caveat. I'll talk about that in a moment. But the bottom line is multiple myeloma in general is theoretically incurable. So when we treat patients with multiple myeloma, we think about first line, second line, third line treatments, et cetera. So what do I mean by that? Well, we use a treatment which we call first line treatment, our first treatment. We use that until patients progress or they can't handle it anymore. Then we go to our second line treatment. We use that until the cancer figures that out, they progress, or they can't handle it anymore. And then we go to third line and so on and so forth. Okay, so we think about several moves ahead when it comes to your myeloma. We know, I know when I meet people typically what my next 5 treatments for myeloma are gonna be, okay? And I'm thinking about how I want to sequence everything long-term. I'm thinking about their future. I'm thinking about years from now, not just the present, right? And so there are many types of bullets that we have in our gun. Okay, and please know I'm not a gun person. I just like using this analogy. So we have biologic therapies that are not chemotherapies that we use to treat cancer. We have a lot of those. They're very effective and they are not chemo. In fact, we very rarely, for the most part, use chemo in multiple myeloma. We do at times, but it's really not a main component of multiple myeloma therapy. It is a part, but it is a secondary part, okay? We have a lot of clinical trials on multiple myeloma, very good drugs on clinical trials, super exciting time for multiple myeloma right now. I'm very proud of my colleagues, very proud of the pharmaceuticals. They're doing excellent, excellent work. Not just colleagues in academia, but also colleagues in pharmaceutical companies. Even my community colleagues are doing tremendous work. So very proud of them. We have very good clinical trials that are ongoing. We have cellular therapy. So we're going to talk about this a lot next time, but we can engineer your immune system cells outside of your body and then give them back to you and have them fight your cancer in a way, in a very specific way, because we engineered them to do so. I'll talk more about that later. That's what you've heard as chimeric antigen receptor C cell therapy, NK cell therapy, et cetera. We're going to talk about that next week, okay? We have molecular-based options, and assuming there's a genetic mutation in the myeloma that might be useful. This is actually not oftentimes useful in your case. I just want to put it here just to be thorough. And then we have stem cell transplants. So what you've heard is bone marrow transplants. We'll talk about that next week. But the bottom line is we have many different bullets in the gun. We are very good at treating myeloma. Okay, so the future is very bright and you have no expiration date. I have patients who have lived 20 plus years and are still going. And so please know that there is no expiration date, but I do want you playing chess against cancer. Now, one thing we do, and we talked about this already, is we do take your bone marrow sample, right? And we do something called next generation sequencing, NGS. And the reason we do that is because we're looking at for mutations in your cancer that we can target, right? So let's say you have a mutation in a purple gene. We might have a purple drug that can target it. Or let's say it's a green mutation in the green gene. We might have a green drug that can target it. Let's say it's an orange gene with the mutation. We might have an orange drug that can target it. So we want to know if there is something in your cancer from a genetic mutation perspective that we can target, which is why we do something called next generation sequencing. Now, this is a mainstay of other types of cancers. For multiple myeloma, it's not as well established. So some people do it, some people don't. It's not wrong if your physician doesn't do it. In fact, a lot of times the insurance will not cover it, okay? But if your physician is doing it, I want you to ask about it, because sometimes it can clue us in to something we can use to attack your myeloma. It's rare, It's rare that that test is particularly useful, but I want you to know that we do it, and I want you to ask about it. Clinical trials are incredibly important, okay? So I'm a big believer in clinical trials. You can hear me talk about it time and time and time again in the series that we've been doing, but these are experiments designed to save lives. They are drugs that we are using or treatments we are using that are not already established to try and extend your life with a good quality of life. They are an essential component of any myeloma treatment long-term. So we'll talk about that in the future. I want you to ask your hematologist about these. I want you to say, hey, is there a clinical trial that you think I should be on every single time that there's an impasse or a fork in the road? I want to say, is there a clinical trial I should be on? They will know. They're very talented. They will know if there's a clinical trial they think will benefit you, but I want you to appreciate that. And if you want to look at them up yourself, you can just go to clinicaltrials.gov and follow the information I gave you in the first talk, that optimizing your ability to fight cancer. You can go look at that. So let's talk about fighting back now. I've given you everything you need to have a foundation. You need to understand myeloma and to know what's happening in myeloma. So let's now talk about fighting back. And so I write this editorial series for biofreematern.com. Don't worry about it. These are illustrations associated with them. You can kind of see I'm a big believer in fighting cancer. I do not sit back and watch cancer. I get heavily involved in my patients' lives. I treat them like family. I get viscerally angry when the cancer gets worse. I get ecstatic when the cancer is better. So you can see I really do believe in fighting cancer. I believe it's a war. I believe it's a battle. And so I take it very seriously. And I think of cancer in that regard like a war. So we talk about the bullets in the gun. Now, there are a lot of bullets in the gun for myeloma. We are very good at this disease, thanks to my colleagues, okay? We're very good at this disease. And what I did for you here is I kind of said, okay, here's the bullets available. There are actually more than this, but this is the predominant bullets we use. And what I did for you is I said, okay, the way I want you thinking about these bullets, these drugs, right, is I want you thinking about them in terms of class of drug, okay? So we have classes of weapons, classes of bullets, okay? So we have anti-CD38 antibodies. So we have these two drugs. Proteasome inhibitors, we have these, and so on and so forth, okay? We're going to dissect this in the future. In the next talk, we're going to talk much more about this. But the idea is simple, right? We want to attack your myeloma on multiple fronts. We want to attack it in many different ways. We want to show it different weapons, different bullets, okay? And so you're going to hear a lot about combinations of treatments, okay? And the reason for that is because we're taking this bullet that is in this class and we're mixing with this bullet in this class, okay? Now, something very important to know is that if your myeloma grows through a treatment, right? Let's say we've shot at it in various ways. You typically are going to want to show it a bullet it hasn't seen. And when I say that, you're going to want to show it a class of drug it hasn't seen yet, okay? There are definitely exceptions to that in myeloma. Oftentimes we'll use drugs from the same class. I'll come back to that, okay? But if you have a myeloma that's, for example, learned how to get through Velcade and Kyprolis, two drugs in this class, it's unlikely going to respond to Ninlora, okay? So you're thinking to yourself, okay, I probably don't want to use that class of drug. I might use a different class, like a BCMA targeting drug that targets a different type of protein called BCMA, okay? So I want you just to appreciate that there's a lot of options. They fall into different classes. And that's really all I want you to get from this slide, okay? Something else to know, though, is we typically use a treatment until it stops working, like we talked about. We will typically go back to the well. You know, we go back and we go back and go back if the cancer hasn't figured it out. So really, if it ain't broke, we don't fix it. I'll talk about that more next week. But I also don't practice insanity and don't want you to be insane. If your cancer has figured something out, you don't go back to the same drug and expect a different result, right? Insanity is just doing the same thing over and over and expecting a different result. We don't do that in myeloma. If your cancer has figured out a drug, we typically go to a different drug. And if it's figured out multiple drugs in a given class, we probably will abandon that class and use a different class of drug. That's all I want you taking from this slide. This is going to be a very nice way for you to understand your myeloma treatments. We're going to use it next week in a way I think is really elegant. But this is a very nice way to conceptualize the therapeutic landscape in myeloma. So, like I already said, we oftentimes will attack myeloma on multiple fronts, and it's really important. So many times, in fact, all the time, essentially, for patients who have high-risk disease, who can have a transplant, we'll talk about in a minute, we will use a drug from this class, a drug from this class, a drug from this class, and this drug. So we'll give them 4 drugs to attack their cancer on multiple fronts, Okay, so you want to show myeloma many different methods of attack. Now, when we talk about your specific treatment, now we just gave you the treatment overview. We need to talk about your specific treatment now. Okay, when we talk about your specific treatment, there are two questions we need the answer to, because these two questions will define what happens next. The first question is, are you a candidate for an autologous, that should be a T, autologous hematopoietic stem cell transplant? This should be a T, sorry. So we need to know if we can do a transplant on you. So let's talk about autologous hematopoietic stem cell transplants for a moment, okay? Because I'm going to talk about that more next week. All that really is, right, is we basically stimulate your stem cells to make more stem cells, and then we collect them, okay? After we've collected them, we give you big gun chemo, a drug called melphalan, to try and kill any myeloma cancer cells that might still be in your body. This is after we treat you. I'll come back to that. But we give you big gun chemo to try and kill any cancer cells that might still be there. The problem is when we do that, there's a collateral damage, and that is the bone marrow. So when we do this chemotherapy, we essentially wipe out your bone marrow. So you don't have stem cells to replenish your bone marrow. So we have to give you the stem cells we've collected back to try and replenish your bone marrow after we've given you that big gun chemotherapy. And that's really what a stem cell transplant is, okay? Now, to be eligible for a stem cell transplant, you have to be of a certain age. Now, this is a moving target. It depends on where you go, right? Some places will do this type of transplant if you're 80. Some places have a cutoff of 75. Generally, the cutoff is 75, but that is very much a moving target. You'll want to speak to your bone marrow transplant physician about that. In addition, we oftentimes look at your overall condition. If you're debilitated, it's unlikely you would be able to tolerate a stem cell transplant. We look at your organ function. If you have major heart issues, there would be significant concerns with the stem cell transplant. We look at other medical conditions. So there are some medical conditions we'd be worried about. No, I'm not a transplant expert. I'm just giving you an overview. I don't want to go into the weeds here. But the bottom line is our very first question is, can you have an autologous hematopoietic stem cell transplant where we essentially give you back your own stem cells? So it's much less risky than the other type, which is called allogeneic, which we'll talk about next week. The second question that we need to know the answer to is, what risk box is your multiple myeloma in? So we talked about the standard risk box and the high risk box, right? So we just take that genetic information we had and we put you in the standard risk box or the high risk box, right? So if you have any of these particular genetic abnormalities, we put you into the high risk box. So the red ones in red are the ones everyone agrees with. The ones in green are the ones that people oftentimes use also, right? So we determine if your cancer is high risk or if it's standard risk. So based on those two questions, right? High risk, standard risk, are you a transplant candidate or not? We then decide what your treatment will look like. We'll talk about that more next week, but these are the two questions I want you to think about, the two questions I want you to essentially know the answer to. So this is an example. I'm not going to go through this today. Okay, we'll go through this next week. I will dissect this for you in a very simple manner to kind of show you what the future likely looks like for you. So there's no significant unknown questions. Okay, there's always going to be questions, but I want to prepare you for those. Okay, so the bottom line is we asked the first question, are you a candidate for a transplant? In this patient, they were, right? Who said yes. And then you say, what's the risk box? This was a high risk person, so they have a specific treatment they would get. I'm not going to go through this today. We'll go through it next time. This gives you a little bit better feel, though, for what you can expect next week. We're going to go through the exact treatment these patients will have, patients like you. And so you will get to see exactly what your treatment is likely to look like in the future. So I'm excited to do that next week. That's really where our focus will be. But please know the take-home message today is that there's a ton of hope and that you don't have an expiration date. This patient was diagnosed in 1999. I'm not even showing that here. 1999, here we are in 2022. He's done very, very well, right? He had to get a drug called belantamab because the disease was starting to take off, but it's back under control now. I'm just showing you part of this. The bottom line is, okay, you do not have an expiration date, and we're very good at treating myeloma now. So in conclusion, I want you to be loud, meaning I want you to ask about the SPEP. I want you to ask about the UPEP. I want you to see your numbers. I want you to see your scans. Just ask. Have your physician sit down, walk you through the genetic part that we talked about, walk you through the molecular profile if they did the NGS, have you talk about clinical trials with them, ask to see the scans. I want you to know your disease inside and out. It will help you follow your disease. It will help you advocate. It will prepare you for side effects. It will just make you a better patient, which I think will optimize your chance at living as long as you possibly can, hopefully forever, right? So that's the idea here. Now, the journey may be different for each of you, but the thought process is the same. So you saw us kind of go from planet Earth down to the continent, down to the country, down to the forest, down to the trees. You saw us do that. You can kind of weave in and out. Listen, again, just focus on the big picture. We gave you a lot of the trees. You can do with them as you please, but just know the big picture is that everything looks really bright right now. The inches matter, but there's lots of right ways to do this. I don't want to go through that too much. You can go watch the first talk we gave called Optimizing Your Ability to Fight Cancer, and then come back here for reference if you need to. I don't expect you to get everything in one sitting. Please come back if you need to. Thank you for spending your Saturday with us. We'll be back next week with the multiple myeloma finale. That's going to be focused on treatment. We're going to do a lot of the clinical trial stuff behind it, a lot of stuff hopefully you don't know. And if you do know, man, you're a genius. But we're going to go through a lot of details, and it should be very fun for you. See you next week, Saturday, 12:30 p.m. You can go to revolutioncancer.com for details. Thank you for your time. I appreciate it. Please take care. Thank you.